Dr. Smith, thank you so much for joining me today. Can you tell us a bit about your background and what you do?
Sure. Thank you so much for having me. My name is Noelle Smith, and I'm a psychologist. I'm also the vice president of clinical care at Moona Health. Moona Health is focused on providing cognitive behavioral therapy for insomnia through a telehealth platform, making it
I
accessible.
think it's such a great option because one of the questions I get asked all the time from my colleagues is where do I send my patients for CBTI? With telehealth, it's becoming so much more accessible. We'll talk a little bit about what Moona does in a moment, but for anyone who's not familiar with CBTI, can you explain what it is and how it's different from sleep hygiene? Because I hear that misconception all the time that CBTI and sleep hygiene are the same, and they're not. So can you explain the difference and what CBTI is?
Sure. CBTI is really the gold standard treatment for insomnia. Sleep hygiene is one small piece of it, but CBTI is much more intensive in that it's going to take a broader look at all of your sleep habits and ask you to make specific changes so that you can enhance your sleep drive and really maybe unlearn some of the habits or patterns that you might have learned over the past months or years struggling with sleep problems. So sleep hygiene might be effective if someone is having difficulty occasionally falling asleep, but for full insomnia where someone has been having significant difficulties falling asleep for more than 3 months and it's really interfering with their life, they can't focus on their work, those types of things, it would be indicated that someone would benefit from CBTI.
Yeah, and I think that's an important distinction as well, because if someone is struggling with chronic insomnia, meaning it's been going on for 3 months or more, problems falling asleep or staying asleep for 3 months or longer, we actually know that sleep hygiene alone is not effective. And I see often in my practice that those patients have the best sleep hygiene, right? They're doing all the quote unquote right things. And CBTI goes much deeper into supporting those patients. Let's talk a little bit about what CBTI entails. What are some of the core components of it?
Sure. Some of the main components are sleep restriction therapy. So that sounds a little bit scary. So we also call it a time in bed restriction. So a lot of times when people have insomnia, they will try to go to bed earlier to fall asleep, or they will stay in bed trying to sleep. And what that actually does, it creates an association between bed and wakefulness. And so we also address what's called stimulus control. That's going to change the association between bed and wakefulness to bed and sleep, which is what we want. So we restrict the time in bed to the time that they're sleeping. They're not going to spend extra time in bed anymore. And any time spent in the bed is going to be spent sleeping. So those are two core components. We also do include some cognitive restructuring. So a lot of times through sleep difficulties, people start developing certain unhelpful thoughts. If I don't go to bed at this time, I won't be able to function tomorrow, or if I don't take my sleep medication, I won't be able to fall asleep. And sometimes those can actually interfere with sleep even more. So we do address some of those thoughts through cognitive restructuring. And then another component is relaxation training. So that hyperarousal, that arousal piece can completely interfere with sleep drive and every good sleep pattern that you might have if you're awake and you're worried about something. So we do have a component of relaxation that can help someone to overcome some of that hyperarousal or anxiety that they might have. And then sleep hygiene is another piece that we add just to make sure that people are not napping or having caffeine too close to bed, those types of things.
It's so helpful to have that framework. And again, for sleep hygiene, it's like dental hygiene. So, you're brushing your teeth and flossing and all of that stuff. But if there's a cavity, dental hygiene is not enough. So that's how sleep hygiene works. It's the foundation, it's important, but it's not enough for people who have ongoing insomnia.
Yes, and a lot of people will say I go to bed at the same time every night, and that's how I'm trying to address it. And that's actually not how we address insomnia through CBTI. And we want to make sure that people have a consistent wake time. And so, really targeting that and the amount of time in bed, the amount of time spent sleeping, those are some of the core components that we do address in CBTI.
One of the concerns that I hear a lot from patients is this is going to take too long. And isn't there something I can just take that's going to work faster, a sleeping pill or some other kind of external sleep aid? And I think there is a misconception that CBTI takes forever or it's going to take a long time to see results. So could you maybe bust that myth, how long it takes for people to start to see improvements? And then how long is a typical course of CBTI?
Sure. So a typical course is going to be anywhere from 6 to 8 sessions. It's typically delivered weekly, but can be bi-weekly depending on schedules and just the decisions that are made with your therapist. but people really do start to see benefits within the first few weeks. So the first week is going to be difficult. I will admit that changing your sleep patterns, especially if you've had them for many years, can be a little bit difficult. So it's not going to have that immediate, let me take the sleep pill and tonight I will sleep, but it does within really 2 to 3 weeks, you will start to see some benefits. The other thing is that it has longer lasting benefits than sleep medication. So all of the research has shown, as well as our work with our clients, we see that over time, even when they're not taking their sleep medication, the CBT-i works longer and helps to have longer impacts on quality sleep.
It's essentially skills training so that when somebody has a flare-up of insomnia down the line, which they likely will, again, at some point in their life, that's just a nervous system response, they'll have the skills to know what to do without spiraling into panic or fear or, being afraid of getting off of sleep aids, which is a common issue that I see with my patients.
Yes, a lot of people are worried about what happens if I have sleep problems again. We do offer follow-up and booster sessions if that is desired, but many clients say, I'm feeling good. I have a really good relapse prevention plan. I know that if I start to have sleep difficulties, which like you said, are very common, you have a stressful day at work, you can't sleep, those types of things. That does not mean that you're going to fall into chronic insomnia again. You have the skills, can begin implementing them, and likely many people continue implementing them throughout. So they're not just using them when they can't sleep, they're using them all of the time. It becomes their daily life, their new sleep habit.
Yeah, and what I love about it is that it also helps people with anxiety during the day, right? The outcomes are not just specific to sleep. We do know there are improvements with depression, with anxiety, with other symptoms. We'll talk about those in a moment as well. But I'm curious, what sort of outcomes are you guys seeing in your clinic, and what are the outcomes in general for CBTI in patients with chronic insomnia?
Sure. We are seeing increased sleep efficiency, which means that people are spending more time sleeping when they are in bed. We are seeing fall faster times before they fall asleep. So instead of 2 hours, we're seeing under 30 minutes. We're seeing fewer nighttime wakenings. So they might be waking up 3 to 4 times a night before they start, and now they're waking up once and they're falling asleep 5 minutes later. They're not turning over in bed for an hour. So we're seeing a lot of improved quality sleep. We're also seeing just an overall reduction in insomnia symptoms. So we do measure that with a self-report measure, and we're seeing a significant reduction in those symptoms. There's also been a lot of research on CBTI and the overall effects. And so it does seem to have some very positive effects on biomarkers as well. So we see things like A1C being reduced following CBTI. So those types of things, we have not tested that specifically at Moona, but those are just some of the benefits of CBTI that research has shown.
It's really incredible to see some of the research and the benefits beyond sleep, like you mentioned, with reductions in A1C and things like this. And maybe we can talk a little bit about some specific patient populations where there are, maybe other challenges like pregnancy, menopause and perimenopause, PTSD as well. How would you modify a CBTI protocol for patients in those different groups?
Sure. And the core components of CBTI are going to be similar. We're going to address the sleep drive and the body's natural sleep-wake cycle. But in those types of cases where there might be additional considerations, we would definitely tailor the recommendations. So let's say in pregnancy, it's not safe for the person to get out of bed when they are 8.5 months pregnant. Maybe they're on bed rest, they need to, but still having insomnia symptoms. Instead of getting out of bed, we might have them just sit up in bed, changing that position so that they're not tossing and turning. So we would tailor it to make some recommendations that can fit for that specific person. And we do personalize all of the recommendations. So we do a very comprehensive intake to understand what might be happening. If someone has PTSD, there's likely going to be a huge hyperarousal piece that is interfering with their treatment. So that might be a bigger focus than someone who doesn't have the same type of anxiety. For someone that also has a diagnosis of PTSD, we might address some of their safety behaviors. So are they doing their nightly perimeter checks too close to bed? Do they have a very solid wind down time? And so we would make different recommendations based on the person and what they're presenting with.
And could you talk a little bit about menopause as well? Because one of the findings that I find really interesting is that CBTI is shown to help reduce vasomotor symptoms, so hot flashes and those types of symptoms in menopause. Could you speak about that? As you can see, there's a lot to learn when it comes to clinical sleep medicine, and we're just scratching the surface in today's interview. If you are a physician or a health practitioner who wants to learn more about clinical sleep medicine in a practical way that you can use in your everyday clinical work, then get my free sleep mini course. I'll put the link to that in the video description below. You can also get it at intrabalance.com/doctors.
The research does indicate that CBTI has an impact on hormones. And so working with them to increase their sleep quality does change some of that. It changes some of the cortisol as well. We also have some strategies that can help with some of the symptoms of menopause. So if someone is having hot flashes in the middle of the night, we might talk about cooling sheets, other type of sleep environment factors that can be altered to also enhance their sleep. So there's a couple different things that we do depending on the symptoms that the person is having.
I love how you can tailor it to these different sort of situations. So, okay, something that I hear a lot, and I see this on social media as well, is that I've tried everything. How is this going to work for me? Or for the clinician who's working with the patient or client who has cycled through every sleep aid under the sun, nothing's working for them, and they're really skeptical that, CBTI, it seems so simple. Like, how is this going to work? What would you say?
It's never too late. So even if you feel like you've tried everything, give this a try. We have specialists trained in CBTI. We also have ongoing consultation. So this isn't someone who attended a one-day training and then they're out in the world providing it. They are having ongoing consultation, ongoing supervision to ensure that you are getting the best quality care. So we know this treatment works even after decades of an insomnia diagnosis, but it has to be delivered in a certain way. And so making sure that the components are there. The other thing is that sometimes people feel like I've tried therapy before, and that might be very different than cognitive behavioral therapy for insomnia. So going to a therapist and maybe talking about your sleep issues might not be the same. This is a very behavioral intervention. And what that means is that we're going to ask you to change some of your behaviors. So just coming in and talking about your sleep problems might not actually help your insomnia, but we make recommendations, and it really does focus on changing some of those behaviors so that you can have a better impact. So it's never too late. You're welcome to come and try it.
I'm so glad that you mentioned the distinction between CBT and CBTI, so cognitive behavioral therapy versus cognitive behavioral therapy for insomnia or other types of therapy. This is not talk therapy, right? So you're not coming in and talking about what's going on. It's not psychodynamic therapy where you're exploring your relationships and things like this. This is a structured approach that is essentially skills training. So you'll leave with skills that you can use for the rest of your life. And going back to what we were talking about before with timelines, I've seen patients improve within a week or two, like you were saying. And you want to make sure that if you are going to be referring to somebody for CBTI, or if you yourself are interested in exploring it for your own sleep issues, that the person is specifically trained in CBTI, like Dr. Smith was just saying, because it is a very different type of approach. And there are specific certifications, training, and supervision that are required for people to administer this properly. So just make sure if you're going to be working with somebody that they do have that training and expertise.
Absolutely.
So what are some of the biggest fears or misconceptions that your patients and clients have before they start CBTI?
Okay, so we hear a few. One you already touched upon briefly is that this is not going to work. I've tried everything. So one of the concerns is that this is not going to work for them. So we always provide education about CBTI. We provide education on just general outcomes, and we help them to understand that this is the gold standard treatment. We also encourage people to kind of keep an open mind and just have an experiment, maybe try to see if this will work to enhance outcomes. The other common concern or common fear that we hear is if someone has read up on CBTI and they see sleep restriction and they think, I'm already not sleeping, I can't restrict my sleep anymore. And so that's why we really try to make sure that the person understands we're not restricting your sleep in the sense that you're going to get less sleep. We want to make sure that you have ample sleep opportunity. However, a lot of time spent in bed is not actually spent sleeping. So we do restrict the time in bed as a component of CBTI. So we just provide some education on what the sleep restriction, which really is a time in bed restriction, we provide some education on what that is and really explain to reduce some of those fears. But those are some of the common misconceptions or fears that people come to us with.
Yeah, absolutely. I think the sleep restriction is the thing that, that really turns people away or they're afraid of it. And I really like how you reframe it as time in bed restriction, or another way that I refer to it is sleep efficiency training. And a lot of my sort of like tech and data-driven and clients really like that sort of framing. And essentially what we're doing is we're helping people connect to their sleep drive so they can feel sleepy and fall asleep and stay asleep through the night. I work with a lot of patients who are interested in tapering off sleep aids. That's just one of the core things that we do in our practice. But for those patients and clients who have been on sleep aids for any length of time, maybe it's just a few months or it could be years, and they're afraid of tapering off, how might you support those clients? What would you say to them?
Sure. And I totally understand the hesitation, especially if you've become reliant on it and you're worried about your sleep worsening if you stop taking it. I mean, it's not a requirement to stop taking sleep medication to do CBTI. We would encourage someone to start the course of treatment and then maybe naturally they will decide, let me try this. We would also encourage them to work with their medication provider. If they are prescribed a specific medication, you would want to wean off with your medical provider, and we would discuss that as well. So if someone's hesitant, they do not have to stop the medication in order to start the therapy, and it can still be effective. A lot of times people start, they see the benefits, and then they do to wean off of it.
That's a really wise approach to also help people have those skills under their belt before they start weaning off, because one of the really important components of helping people wean off benzodiazepines, we actually did a video about that last week. For anyone who's interested in learning more about benzodiazepine tapering, you can check out that video. We'll link to that. But it's important that people feel empowered and confident in that process, and they feel like they have something that they can do, because otherwise it can feel very intangible and very scary. So I think it's great that you offer that sort of approach to supporting those patients and clients. So one of the challenges with any type of behavioral intervention, whether it's CBTI or something else, is adherence, sticking to the plan, following through, and then also having the support. So how at Moona Health do you support clients with staying on course and following?
Sure. So we do have a platform where people will fill out their sleep diary. Their sleep diary is a core component of therapy. So without the sleep diary data, we don't really know what's happening. I made the comparison that it's of like we're trying to adjust blood pressure without a blood pressure measurement if you don't do the sleep diary. So you want to make sure that you're doing the sleep diary. We have a platform where they can easily complete it, and then the clinician can go in and see that sleep diary. So if there's any issues or we see that it's not getting done, we can address it in the weekly therapy session, or we can also address it through a message. So we do have communication with our clients throughout the week if needed, to be able to ensure that we have the data needed to make appropriate recommendations for that person, because we want to make sure that it's accurate and that it really is driven by their specific sleep scenario.
For the person who's using a tracker, maybe they're using an Oura Ring or an Apple Watch or some other kind of wearable device, would that work as their sleep diary? Do you integrate that data, or how do you use that information?
So we don't integrate that data, but that's definitely something that you can review to enter. We ask for the time that they fall asleep, so that can be used for that time to get that time, as well as the time that they get out of bed. So they are able to use that and enter it into the sleep diary, but it's not integrated.
If a clinician is working with a patient or client and they're wondering if this person is appropriate for CBTI, how do they decide? Like, at what point should they say, okay, you need a referral, or at what point might they continue working with them on whatever they've been doing so far?
Clinicians should consider CBTI anytime there's insomnia symptoms that interfere with quality of life. So if you have someone that is having difficulty falling asleep, staying asleep, waking up too early, at least 3 nights per week, and that's been going on for a few months, and it's causing some type of interference, then that would likely be an appropriate referral. If there's no underlying medical condition or an untreated psychiatric condition that really needs to be addressed first, that could be another good referral. But if a patient expresses that they have a desire to go off of sleep medication, they're looking for something else, all of those would be appropriate referrals. Referrals that we get are ones that have been discussed with the patient. So the referring provider has told the client about CBTI, has let them know that they will be making a referral, has told them about what to expect, so that the person showing up is aware that they will be asked to track their sleep and make some changes. So those are some strong aspects of the referral. But if anyone has a diagnosis of insomnia, it would be appropriate.
And along those lines of patients who may have other conditions, whether they're psychiatric or medical comorbidities, are there any referrals that are not appropriate? Who would not be a good candidate for CBTI?
Sure, if they don't have insomnia, that's going to be one. Other cases would be untreated bipolar disorder. There is a risk of mania from sleep deprivation, which can happen in the early parts of CBTI. The other one that we see a lot comorbid with insomnia is sleep apnea. That's completely fine if they have a CPAP and they would like to address their insomnia symptoms. But if they have untreated severe sleep apnea, we would recommend that they get seen for that and have a CPAP or whatever the appropriate recommendation is before starting, just to make sure that they can safely do CBTI. Any active substance use disorders that could interfere with treatment, we can still provide CBTI, but if it's going to be treatment interfering, then it likely isn't going to have the best outcomes. And then if there's severe cognitive impairments that would make it difficult to even do like the sleep diary or follow any of the recommendations, we do have cognitive strategies that we can implement to help people that are having some memory problems. But if it's very severe and they cannot do the sleep diary and they cannot follow the recommendations for time in bed and the sleep window, those types of things would not be indicated. The other case would be if they are a night shift worker, though that is typically not indicated for a referral as well.
Okay, that's really helpful. And I'm curious if you have any cases that you could share just to illustrate the transformation with CBTI.
Sure. And actually, this one that I thought of is a 50-year-old woman. She came to us 20 years of using a sleep aid and was worried about the long-term effects, even though she had been on it for a while, but wanted to stop using the sleep aid and had heard about this through a friend. She was a little bit hesitant, felt like it might not work for her, but she was willing to try and she was committed. So she, within 2 weeks, she was tracking her sleep, following everything perfectly, was doing very well with adhering to the rise time, all of those things that are core components of CBTI. And by week 4, she was falling asleep naturally within 20 minutes. And she had been taking hours to fall asleep prior to that, even with the sleep aid. So she was a little bit concerned about weaning the medications. She had some thoughts about, I need this to be able to sleep. I won't be able to function tomorrow. By week 4, she was also challenging some of those thoughts herself. We hadn't even started the cognitive restructuring piece. She was wondering, maybe I don't need this, and started working with her doctor to taper off of the medication. So it was really a great example of someone who had been suffering for a very long time with insomnia, was very reliant on the sleep aids, was even initially reluctant to go off of the sleep aids, but by the end of 8 weeks was falling asleep quickly, staying asleep, and did not afford a whole new quality of life during the day. She wasn't as sleepy. And so it was really a heartwarming case.
I love stories like that. It's life-changing, really, for people because sleep doesn't just impact what's happening at night, but it has an impact on their daytime experience, on anxiety, relying on these sleep aids, like you said, that has an impact on their overall physical and mental health, and there's long-term repercussion. There's so many downstream implications to
Yep.
having insomnia. And so it's just amazing to hear stories like this.
And same thing with relationships. They struggle when you're irritable because you didn't sleep well, or work performance. So we've seen all of those areas of life positively impacted by therapy.
I've had people ask me, is it the same if we do it in person or digitally? Is there anything that's been surprising for you to offer CBTI via telehealth, or anything you'd like people to know about in person versus online?
Sure. There are a lot of concerns about telehealth, saying that it might not be as effective because there can be barriers if someone doesn't know how to use a computer, those types of things. We do try to streamline it at Moona to make it as easy as possible by having a link and providing support. What has surprised most is actually the level of engagement and satisfaction with the therapy. So this is a relatively kind of difficult treatment in that you have to do things. You have to track your sleep. You have to change your behaviors. And so we were a little bit unsure of how clients would respond to that. And they absolutely love it. They love the convenience. They love that they're able to get in quickly, and that they're getting personalized care to really help their specific sleep problem.
So do you have a core message for any clinicians who aren't referring their patients for CBTI?
So referrals are easy. We at Moona accept many insurances. We can get the clients in quickly, and we provide the clients with gold standard treatment. So you can feel confident that they're going to be getting good quality care, because that's my job, and ensuring that. And this is a safe, time-limited, and highly effective therapy that can really change their life. So please feel free to send a few patients to try it out and see the results for yourself.
What states can you see patients in?
We're currently in New York, New Jersey, and California, but plans to expand within the next year.
Okay. And for anyone who's struggling personally with insomnia and they're watching this, what do you want them to know?
So I would just let you know, insomnia is treatable. It doesn't have to be a lifelong condition. So you don't have to live like this. CBTI helps you to unlearn some of those things that might be keeping you stuck and that might have actually saved and helped you in the early stages of insomnia, but are potentially unhelpful at this point. So relief is possible, and it's often faster than you might think.
Where can people learn more about CBTI or connect with Moona Health?
So you can visit us at our website, moona.health, and explore our platform, learn more about the therapy that we provide. We also provide resources, webinars, and support for clinicians and patients that are interested.
Do you have a favorite or personal sleep tip that you like to recommend?
My personal favorite, and it's a core component of CBTI, is the consistent wake time. People underestimate the value of that. They like to sleep in on the weekends, but I use the comparison. Even if you sleep in 1 or 2 hours, it's like traveling time zones, which can take a few days to get your body back on track. So consistent wake times, that's one of the most helpful approaches that I've found, and something that I implement in my daily life.
That's my personal favorite too. Yep, consistent wake time. Yeah, like you said before, a lot of people focus on that consistent bedtime, and that's really not all that helpful, especially if you have insomnia. But that consistent wake time, it's your circadian anchor, and it sets you up for the rest of the day. So I love that.
Exactly.
Great. Thank you, Noelle, for joining me today.
Thank you so much. And if anyone has any additional questions, happy to be a resource.
I'll put the links to Moona Health and other resources in the video description below. So go ahead and check that out.